and its initiatives. Now, I would take the privilege to introduce Dr. T.S. Parmar, the MD and CEO of Albert David, who will initiate the proceedings of the webinar series. Dr. T.S. Parmar has over 33 years of experience with leading MNCs and Indian pharma companies. Dr. Parmar has done his PhD in healthcare marketing, and he has recently submitted his final thesis for his second PhD in healthcare strategy through MIT University. Dr. Parmar has additionally done his Masters in Management and Executive Management courses at IIM Ahmedabad and ISB Hyderabad. His expertise spread across the width of the functional roles, including marketing, sales, strategy, merger and acquisition, general management, and teaching. Dr. Parmar is multifaceted personality. He is passionate academician. He has been regular executive management courses and on IIM Ahmedabad and ISB Hyderabad, including his expertise spread across the width of the functional roles. He is also a regular and popular keynote speaker, panelist in various conferences, symposiums, webinars in India and abroad. I will request Dr. T.S. Parmar to introduce the concept of his webinar series to the audience.
Thank you so much, Ashish, and very good evening, dear doctors. It's a great pride and pleasure to introduce to you a special knowledge enhancement platform, Vedanam, supported by Albert David. The meaning of Vedanam is sharing of useful knowledge and insights. Through Vedanam, we at Albert David Limited intend to create a common platform for all the orthopedicians to come together and discuss their clinical cases and success stories, which can then be applied and replicated by the other orthopedicians for the betterment of bone, joint, and muscle healthcare. We are sure that during the course of this webinar, we'll be able to discuss and debate on various issues related to the topic and contribute in the process of information dissipation. With this platform of Vedanam, I now have the pride and pleasure of introducing to you the chairperson of today's webinar, Dr. A.S. Prasad. Dr. Prasad is a well-known personality among the medical fraternity, and he began his illustrious career after completing his MS Orthopedics in 1985 from GSVM Medical College, Kanpur. Dr. A.S. Prasad has completed more than 17 international training and fellowship courses across the world in Germany, in USA, in Australia, and many other countries since having done his MS Ortho. Dr. Prasad is also a faculty in various courses, both basic and advanced, in various joint replacement meetings in India and abroad, and in various associations across the country. He's also done many live joint replacement demonstrations across the country in multi-city workshops. Dr. Prasad is a founder and president of the Arthroplasty Society of UP, and he organizes the Kanpur Arthroplasty course every year since 2005 with the help of international and national faculty. He obviously has many papers and publications to his credit, and many surgeons have trained under him. I can go on, but I think we all are eager to listen to Dr. Prasad and our other eminent speakers. So with this short introduction, I would like to hand over the technical part of this webinar to Dr. Prasad. Over to you, sir.
Thank you, Dr. Parmar. And I think I will look forward to even listening to your talk after looking at your credentials. So definitely which has to be very important.
Thank you.
Good afternoon, friend, or rather good evening now. Friends, today we'll be having a case-based interactions. And what we have done, we have really arranged a variety of beautiful cases. I'll not go into details because that will take the flavor off. But yes, I'll just touch upon it. There are three faculties, where one is from Dr. Pawan Chabi from Bangalore, then Dr. Sanjay Dhawan from Agra, and definitely I'm also there. We all will be sharing our interesting cases, and they're really such a diverse that you can look into it and can relate with the cases. Yes, you have seen some cases like that. And what are the options available that will be discussed in length? So we are not going to keep it short, but definitely we want it to be crisp. So that's a request to the faculties. And I'm really thanks to Dr. Parmar and his team, and especially the new platform, the Vedanam, which looks so exciting to go ahead. Because the culture, we are always looking back, and Ved always denotes a source of knowledge. So that name itself is very catchy. And thank you, Dr. Parmar, for bringing us on this Vedanam. So can we have the CV of Dr. Pawan Chebi to start with? He's a surgeon based in Bangalore. He's consultant surgeon of Apollo Spectro Hospital. Special interest in sports injuries, arthroscopy, deformity correction, and joint placement. Undergone extensive training on the knee joint for 2 years. Has been on-field sport consultant at India and Australia. And definitely you will see his cases and realize why he has got so much of varied interest in knee and shoulder. Dr. Pawan Chebi, all yours. We are looking forward to hear your cases now.
Thank you, Dr. Prasad. Thanks for the introduction, and thank you, Dr. Parmar, and good evening, Dr. Sanjay, and all the other members from Albert Davis and the participants. Right, so I will be discussing about two very interesting cases on the knee joint itself. So in December 2018, I received a patient of 35 years old who had complaints of stiffness in the right knee joint and had an inability to walk. He also had pain and deformity in his right wrist and pain and deformity in his left elbow. Now, he's got a very interesting and extended past history. In April 2018, he had a road traffic accident with head injury. He had a right distal radius fracture, left distal humerus fracture. He was treated for head injury for 5 months, and later, after 5 months, the distal radius was tended for and the distal humerus was tended for. Since he was bedridden with peritonitis, the right knee joint slowly developed stiffness, which was unnoticed. So later on, they somehow they noticed it and they started physiotherapy. With physiotherapy, they could get a few degrees of movement, but subsequently the pain started increasing a lot. So at that point of time, when the pain started increasing, they had to stop the physiotherapy at that moment. Yeah, so on examination, he had a stiff knee gait. He had, an antalgic gait was also present. He had gross wasting of the muscles around the knee joint, around the right knee joint. He could not walk without support, and he had to take someone else's help to walk because he couldn't use crutches because of his right wrist and his left elbow also being affected. Can we play the video on the slide? I think it's not playing. Never mind. So he had to walk with support. So after that, on examination, we found a fixed flexion deformity of about 80 degrees, and over that, a flexion of about 5 degrees was present. Gross tenderness of the patellofemoral joint with marked tenderness of the medial aspect of the knee joint. The medial knee joint line was not palpable. In fact, I could find a very tender, firm to bony, not a mass or a lump or a fullness rather in that particular area. And he of course had a loss of patellofemoral movement on palpation. So I couldn't have on palpation and allotment of the patella, I couldn't have any movement at that point. And the tests for stability were all negative. So the other joints, right hip and foot and ankle, were normal. He had a deformity of the right wrist joint with ulnar prominence. distal ulnar prominence, and left elbow he had fixed flexion deformity of about 60 degrees with crepitus. So I had to come to a differential diagnosis after the examination part. So possible differential diagnosis were Pellegrini status disease, myositis ossificans, heterotrophic ossification, probably because of his head injury, knee osteoarthritis, medial femoral condyle avulsion fracture, medial lateral MCL sprain, medial meniscus tear, or Apes tendonitis. So what we went ahead and did was an X-ray. So we found on an X-ray in December 2018 gross ossification of the posterior medial aspect of the knee joint. The intra-articular space was normal and there was no anterior-posterior tibial translation. The MRI scan was not done at that point of time because the patient had a stainless steel implant in his left elbow and his right wrist. So later on, after that particular thing, I thought that I will talk to you later why I gave him about 3 months time to come back for the next follow-up. So later on, in the month of April 2019, I went ahead and got a CT scan done with 3D reconstruction, which showed an extra-articular, well-formed bony deposit on the posteromedial aspect of the knee joint, probably arising from the medial collateral ligament. Okay, so since the knee was flexed, I could see most of the ossification on the posteromedial aspect. So that makes sense because the sagging of the MCL in flexion. Also, there was a chip fracture seen on the lateral aspect of the patella, on the patellofemoral part. So you can see the same images around here. So you can see the well-formed ossified ossification on the posteromedial aspect of the MCL or the medial aspect of the knee joint. And you can see it is more proximal, not so much on the tibial side, but more on the femoral side. Few more images of the same. And you can also appreciate the little chip fracture of the lateral patella. So we made a diagnosis of a Pellegrini state ossification of the medial collateral ligament. So what we did was, I spoke to the patient. We did try physiotherapy for some time, but then later on the pain started to increase. So I went ahead and I opened up the lesion. So on the medial side, we opened and excised the ossification over the medial collateral ligament. As you can see here, this is a well-formed ossified center. It had its own capsule around it. After the excision, we didn't find any discontinuity in the MCL. So it was pretty much intact. Only 1 or 2 fibers of it had come along when I had to take out the whole lesion. But then it was pretty much continuous. On table, we got about 10 degrees of extension and about 10 degrees of flexion. That's it, nothing much. So it was a little disappointing at that point of time, just immediately post-operatively. But then, see, there you can see this is the lesion, which I'm separated from the MCL at different angles. And this is the exact lesion, how it looked in the 3D reconstructed CT scan images. So we found that the MCL was intact, the adductor magnus was intact, and we could also see part of the MCL. I could palpate the part of the MPFL. That was also fine, and there was no instability as such post-operatively, valgus instability or varus instability post-operatively. So what we did was we did an arthroscope as well, and there was no intra-articular abnormality seen anywhere. And there was a little bit of contractures on the more on the lateral part or the lateral patellofemoral part, which we did a fibrolysis with a coagulator, and I couldn't really see the fracture fragment, and after the fibrolysis I could find the patellofemoral joint movement, which was quite okay at that point of time. Active flexion and extension with the help of hinged knee brace was started immediately post-operatively. So these are the post-operative X-rays, As you can still see, the flexion deformity is still there. This was the immediate post-op. Then at the time of suture removal, within a few days, say about 2 weeks, the fixed flexion deformity was reduced to 20 degrees. And on table also we couldn't get that, but then it reduced in 2 weeks. And the patient was able to do about 90 degrees of flexion. Physiotherapy was continued with a hinged knee brace for about 6 weeks. Near normal extension and complete flexion was possible. Now the patient can walk without support and with a normal gait cycle. So, Ashish or Biju, can you play this video? Is it possible?
Video is not being supported here for this. Only
never mind.
Or the image will come.
Okay, never mind. So you can see him. He's walking down from there, and I mean, the video is not active, but then he is walking without support, and he's able to walk normally. Of course, he had some sequelae because of the head injury, and he was he's still taking Levipil, but he is pretty much well oriented with what is happening around, and he is cooperative, and he is aware that he has to do a constant physiotherapy. So this is the recent follow-up photographs with the complete extension and complete flexion of the knee joint. So what is this Pellegrini stera disease? So whenever there is an injury to the MCL, this causes damage and acute inflammation that sets a motion of delayed ossification of that particular ligament. It has been seen in knee joints without any trauma, but probably sometimes people who have head injuries, brain injury, or spinal cord injury also can develop this without any obvious trauma to the knee joint. So the ossification is not confined only to the superficial MCL, but then it is very much found in the proximal part at the ischiocondylar tendinous portion of the adductor magnus on the adductor tubercle, and that we found in this particular case as well. Recent studies have suggested that the posterior MPFL also can be involved in this particular condition, which was examined in our case as well, and we didn't find anything of that sort. Now, sorry. Right. So another few of the studies suggest that repetitive microtrauma, which happens due to therapeutic manipulation of the restricted knee joint, is a possible etiology for Pellegrini stera disease. And now what happens is, when this patient was, as the history of the patient shows, when he had this particular injury and then manipulation was done and it couldn't work and so on and so on, probably that is where it set in the motion. And when I saw him in December 2018, on the X-ray, the ossification was not complete. So I had to wait for him to come back till the ossification was complete, which was suggested by Pellegrini himself, that ossification, unless until the ossification is complete, the excision will not hold good result, and there is a chance of recurrence which can happen. So, and also most importantly, physiotherapy can be one of the cause, or repeated manipulation can be one of the cause of increased ossification of the MCL. So in this case, as discussed earlier, physiotherapy was not playing a great role. In fact, if it was overtrained, there was a risk of progression of the lesion, also potential risk of the MCL tear. For this lesion, surgical excision was the only and the best option. There is usually post-surgical excision, there is a large ligamentous defect which we can expect in the MCL. Luckily, we didn't have anything of such. And there is a high recurrence rate in this particular, after the excision of this lesion. But in our case, we didn't really, in our case, what we saw that we had to wait till the particular lesion had matured. So here, as the old data from Pellegrini and an updated Kulowski study showed that complete surgical excision and continued physiotherapy can prevent the recurrence as effectively as possible. But then the point over here is we have to wait till the lesion matures and then we have to excise it. So in conclusion, the present condition of the patient is being closely monitored, and apart from daily walking and physical activities, physiotherapy is being regularly performed. Patient is advised to report back if there is any pain, stiffness, swelling around the knee joint, or anything similar complaints which happens on that particular knee joint. Yeah. So now there is this particular poll question. So do members here, do you give indomethacin for patients with head injury and orthopedic polytrauma as prophylaxis?
There are 15 seconds for the audience to answer this poll. Couple of seconds more. Fine, we'll end the poll now.
Right, so 50-50. All right. See, there is evidence, there are numerous papers which talk about indomethacin being helpful in preventing, but then in Pellegrini-Steda syndrome, there is no evidence. I've tried to search, but I didn't find anything. And most importantly, most of the times, orthopedic surgeons forget to start indomethacin, after a head injury. And I try to make it a point as a checklist so that, I start to give them indomethacin as, a preventive measure for developing, increased or exuberant callus or conditions as such. So I think that ends my first talk. So Ashish, how do we go next? Do I continue with the second case as well?
Go ahead.
All right, fine, good. So, August 2019, I received a male, 29-year-old male, active male, who was a university-level sportsman. He was a sprinter, actually. The primary clinical diagnosis which I made was chondromalacia patella and patellar tendonitis, which was very, very similar to that. And he responded very well with physiotherapy. After about a week, 2 weeks, he was fine. But after a month, he came back with marked swelling and pain in the knee joint, right knee joint. He had mild fever. He had a small little antalgic limp and increased temperature over the knee joint. The range of movement in terminal flexion was a little painful. He had effusion of the knee joint and tenderness over the proximal pole of the patella. So this is the clinical picture of that gentleman. You can see marked effusion of the knee joint. He didn't have any past history of any such lesion in any part of the body. So what we did is we got a X-ray and we got a CT scan done, CT MRI scan done. So we could see that there was a sclerosed lesion inside the proximal pole of the patella on the lateral aspect, with a small little probably a sequestrum or probably a nidus. We didn't know at that point of time. So this is how it looks like. And on MRI also we could confirm that, and there was so it was well within the patella, and it was not spreading outside. But then his prepatellar bursa was inflamed, however, and there were multiple loculated cysts there as well. Apart from that, he had a small little anterior root tear of the medial meniscus, which really didn't bother him because he was a sportsman. He also had a posterior part of his medial meniscus was a little torn, but that was not the main bother for him. There's some more films here and there. So this was the report which we checked and cross-checked with a radiologist, and it was found that there was a focal abscess along the supramiddle aspect of the patella with erosion of the adjoining marrow edema. So there was a sequestrum, that little dot there was a sequestrum which was there, and there was a significant joint effusion and mild synovial thickening which was also there, and of course the septate suprapatellar bursa which was inflamed, and other things which I've already told. So we came to what the MRI says was that, but I also had these particular things as my differentials, that is osteoid osteoma of the patella. One of the reason why I thought that was the presence of nidus, and also it was probably a post-traumatic cyst because he was a high-intensity performer and trainer. So we did an open and arthroscopic curettage. So you can see the image on your left side, which when we opened the particular lesion on the top, and when I was trying to take the layers of the lesion with my 15 number blade, it immediately collapsed and it made a hole right there. And then it was a very soft lesion, and I could just put my little finger and move it around, and all the loculi, everything opened up. And it didn't take long for me when I was using the curette to form this particular lesion on the right. So it is going intra-articular. You can see that the intra-articular fluid also over there. So this is what we saw inside the scope. This is, as you can see, that's the part of the quadriceps and the superior-most pole of the patella. And that was the hole which was formed. So on table, I thought that this definitely can be or is an infectious cause. So I immediately ordered for Stimulan, that is antibiotic beads. I mixed up with vancomycin and gentamicin and placed it over there. So post-operatively, he was in a long knee brace for about say 3 weeks, and he was given knee bending exercises on a hinged knee brace for a couple of weeks, and then without the hinged knee brace. Surprisingly, culture sensitivity showed no growth, and the HPR showed suggestive, said that the features are suggestive of osteoid osteoma. So it was a little surprising because microanatomy didn't look like an osteoid osteoma; it looked very much like an infection. However, this is what it, the HPR showed. We did a cross-check with another pathologist who said that very weak features of osteoid osteoma, not much of, and it showed some features of chronic inflammation. That's all. So right now he is not here. He was supposed to come for a follow-up, but because of the pandemic, he's not able to come down here to Bangalore. So this is what the photos he sent from his house. He's perfectly all right. He's doing well. There is no pain or anything as such. It took about roughly 5 months for us to get the full range of movement. I was a little careful because I didn't want, because it was very thin bone. I started to do the exercise very slowly, and we did a guarded physiotherapy. Now he's fine, and he hopes to return back to his sports in about 3 months of time. So my primary differential or my diagnosis was osteomyelitis patella, because most of it fit into the symptoms and the anatomy, the microanatomy, pathoanatomy. So it's a rare condition in adults. It is commonly seen in children between 5 to 15 years. In adults, however, causes are repeated trauma to the patella with prepatellar bursitis. A person who has got a lot of prepatellar bursitis frequently because of repeated trauma can have it. Diabetic is known to be one of the cause. Immunocompromised patient is known to be one of the cause, and IV drug abuse also has been known to be one of the cause. In this particular gentleman, I think probably the repeated trauma, probably he was because he was a sprinter, and probably he didn't do much of stretching or something like that. And I had to rule out tubercular osteomyelitis also, but that also he didn't have any history of such, no constitutional symptoms, and HPR also didn't suggest that. So usually in osteomyelitis, the patella is highly sclerotic and is irregular. So it becomes extremely irregular and it tends to get adhered to the surrounding soft tissue, which is not the case in this person. So curettage and IV antibiotics is a preferred way of treatment. Antibiotic beats application in case of a patellar osteomyelitis is not been reported, but then it is definitely an effective way for treating other osteomyelitis, so which was carried out by me. The same thing was carried out by me. Whereas the initial confusion of osteoid osteomyelitis very rare. It's very rarely located in the patella, and it accounts to only 2% of the lesions affecting the patella. So MRI, you can see a well circumscribed lesion with a nidus. Microscopically, it's a very hard lesion. So it's a bone-forming lesion. So it's a very hard lesion, which was not the case in our this thing. And microscopically, it is pretty much easy to detect because it has these bone-forming lesions and the stains and all that. It tends to pretty much show that it is an osteoid osteoma. With a nidus, you can never miss. So the treatment for osteoid osteoma is CT-guided radiofrequency ablation or CT-guided percutaneous excision. For large tumors, however, surgical excision with or without filling of the defect is recommended with a bone substitute. And there are some reports of patellectomy or partial patellectomy also, which has been done for this condition. Right. So, in conclusion, the patient is asked to watch out for his symptoms. I had probably 3 follow-ups with him before he left away because of this pandemic. And since it's been 1 year post-operatively now, we have started him some exercises and weight-bearing exercises, extensions and all that. So after the next assessment, I would probably allow him to return to his active sports in roughly about 3 months of time from today. Well, I think that ends my presentation. These are my references.
Thank you.
Thank you.
Thank you, Dr. Pawan. So friends, next we are going to have Dr. Parmar. He will be talking about digitalization in our clinical practice. This will be an overview just to sensitize us, the medical practitioners, medical services, how it's going to work. Welcome Dr. Parmar for his lecture. And thank you, Dr. Pawan. We'll be asking some questions. I think I have got a couple of them. So that will be at the end. We'll go serial wise when the session finishes. Thank you.
Sure, Dr. Prasad.
Talk.
Thank you.
Thank you so much, Dr. Prasad. Ashish, you wanted to show audio vision?
Ashish, Mr. Ashish is disconnected due to a slight technical snag. We would be taking a small break, which will be showing a small video. After which we will have Dr. T.S. Parmar's presentation.
Yep. Now, what I request Dr. A.S. Prasad
Yeah.
to enlighten us regarding a brief overview of digital connect for the medical, and then invite Dr. T.S. Parmar for the second lecture session.
Yeah, so that's why I thought the movie was given first time. But anyway, so Dr. Parmar, again, we are looking forward to your lecture on digital initiative in medical practices. So, in fact, we all are going through a difficult times, and we all are trying to use our known digital methods. Even I'm doing all my consultation on video platforms. So there are many platforms in the market who are trying to help us, even in dispensing the medical medicines also. So I think this talk will be good to give us some insight into how the world and the future holds for us. Please, Dr. Parmar.
Thank you so much, Dr. Prasad. I totally agree with you that in today's fast evolving world, the only constant is change. And in today's changing environment, one hot buzzword that's doing the round as a catalyst of change is COVID. And a close competitor to COVID is a word which is digitalization, ITization, or a change into new technology. And this is exactly what I'm trying to do in this session of mine. It's a very sensitization and abridged session of a more elongated session I normally take. But the idea is just to give a cursory introduction into the digital initiatives in medical practice. And it's not as if this thought process has just got initiated. A pride of India, who is Satya Nadella, the CEO of Microsoft, 5 years back in 2015 had said that every business around the globe, including in India, will become a software business, even if it is not an IT-based business. And so true he was, because come year 2019, and we saw an influx of artificial intelligence, telemedicine, Internet of Things, and a whole lot of these things, including machine learning, robotics, and blockchain technology, which started doing a great inroads into society, personal lives as well as professional lives. And start 2020 and the initiation of the disruptor COVID, we have seen an acceleration of this digital transformation, which is making deep inroads, fast inroads, both in our personal, social, as well as professional lives. Let's have a look at some of the statements which were made. Pre-COVID, there's this statement which came which said that healthcare lags other industries in digital transformation as well as customer engagement. But come 2019, we have this Times of India quote which says, in COVID-19 times, online digital platforms are helping doctors stay connected and further help their patients. So digital platforms have definitely been a good support, especially in these, as Dr. Prasad said, very tough COVID times. And there's this statement which came in Economic Times which said that healthcare in 2020 onwards is going to be an era of digitalization. How much of it, how fast, we will see in the coming slides. And I have this very hot data, which is exclusive data, which we have got permission to share through a friend of mine who is Dr. Sanjay Mitra, where SMSRC, which is the leading prescription audit agency in India, and Purdue University, USA, collaborated. And this is the second version of the study. The first one happened in March, April, and May, where more than 6,000 doctors, over 20 specialties, 80 cities were researched. And this is the data on 2,000 specialty of doctors, including orthopedic surgeons, in 80 cities in the month of June and July. so just a month away from here, where this data clearly shows that you still had 38% of doctors who were doing physical consultation during the COVID times. Just a qualification here, most of these doctors were in the rural areas. 12% of doctors were purely digital, and 20% of the doctors did a mix of physical and digital. So you add 12% and 20%, 32% doctors vis-a-vis less than 10% of doctors who in India were digital. So there's been a threefold increase in the digitalization by doctors. Of these 32%, 96% of the doctors used only mobile and WhatsApp. And only 4% of the doctors who had gone digital used any of these advanced apps. So there's a long way to go for digitalization, but it is happening. It's slowly happening. Maybe by default, because of COVID, there's a force. We are unable to go to our clinics and hospitals, or were at least till last month, and the patients are unable to come to us as frequently as they were doing in the past. There's another data which might surprise us, which shows that doctors were willing to meet the pharma industry and other professionals from the healthcare industry. 53% of them were willing to meet them physically in the coming 2 to 3 months. And 24% said, no, it will be a mix, we'll reduce the frequency, it will be a mix of physical and digital. So 77% of the doctors said that in the next 3 to 6 months, we will come to a mix of physical and digital meeting. Only 23% said, no, let's wait and see. Now, with this hot data on the side, let's move on to the new world, new norms, or the new buzzword, which is new normal. Let's go to the next slide. And this is a new normal which is going to affect us both personally, socially, and professionally. So pre-COVID and post-COVID is going to be different. In the COVID era, we are going to see sanitization, screening, protection, which has already started, which is compulsory. But along with that has become this and intervening of technology, artificial intelligence, blockchain technology, and all these technological and digital tools that we were talking about. And all of this is going to impact our practice, is going to impact the drug discovery, is going to impact the way we have been doing medical practice in the country and globally. But what has also changed dramatically is the digitalization at home. We used to see maybe digital thermometers, maybe we used to see a glucometer or maybe a BP machine at home. But today we also see many households who have SpO2 oximeters. So that's one major change that's taken place. There's also been a surge in telemedicine in the COVID era. As per this data, and I'm not promoting Practo, but there's been a 50% rise in the doctors who have joined the Practo platform or other digital platforms. One specialty gynecology data which was available shows, and I'm sure it also reflects similarly in orthopedics, 250% increase in online consultation or online queries between the consultant doctor and his patients. Let's see more data. A lot of apps are available. What I'm going to do is just a sensitization or overview. So I'm not going to go into details of the apps. And there's a disclaimer, I'm not promoting any of these apps. Some of you may already be using these apps, especially for your appointments and counseling. Some of the more popular apps are Practo, Boost, CareCluse, and maybe some other local apps. In diagnostics, you have MedLife, you have SRL, Apollo Diagnostic, Metropolis, Thyrocare, and many others which may be available locally. For online medicine, there's been a major shakeup. There's been a tsunami in the last fortnight where Amazon and Jio have actually come and bombarded the space. But the other popular apps which were available were 1mg. Let's go to the previous one, please. 1mg, Pharmacy, NetMeds, and many others who are available as online pharmacies. But what patients and doctors and professionals today are looking at are not one vertical apps. We are actually looking at a one-stop window. One app serves all needs, which includes appointments, online pharmacies, consultations, physiotherapy, diagnostics, radiology, insurance, and all the requirements. And yes, hold below, We have India, which has actually catered to this need. India is an IT hub. So we have White Coats, we have MedSign, we have MediQS, Doc Engage, Librate, Health Connect, and many other apps which are one-stop, single-shop windows for all the needs in healthcare. Now, how could the government of India, which also claims, how do the Indian government, which claims it's IT savvy, lag behind? So, Indian government has also, this is a crowded slide. I'll go to a few of the apps which are more popular. We have the NHP Indradhanush immunization app, which is a very useful app as far as immunization program is concerned. And today, immunization vaccines is one of the buzzwords which is doing the rounds. There's another app. Dengue is definitely a seasonal problem in India and many other countries. So you have a dengue app, which is both an awareness, prevention, cure kind of an app, which gives a lot of assistance to the entire healthcare community, including the patients. There's another app which is helping us, which is a 360-degree kind of an app. It's a Swasth Bharat mobile app, which talks about how to live healthy, diseases and the symptoms, at least India-specific diseases, the mode of treatment, and the general information that a layman needs to know as far as the disease burden in India is concerned. So this is another very general knowledge kind of an app. I couldn't find an ortho-specific app, but this is a mother and child gynecology app, which is known as the Kilkari mobile app, which helps in sending audio messages to the pregnant women about the birth of the child and related kind of information, which is very useful. We also have another app which claims that it is the largest online platform for doctors, and it's named Omnicurus, which gives accredited medical CME programs, latest medical news, conference highlights, and the like. So this was a quick take on the apps which are doing the rounds in India. I'm sure many of us are using a couple of these apps. Some of them may be new to you. We are not promoting any particular app, but just trying to say that you have assistance to complement your practice and support you. With this, I now move on to my next slide, which is poll question number 1, and request your participation. We have 15 seconds. We are not talking about today and future. Currently, what is the level of online consultancy, whether it's a TCon, WhatsApp, or others that you are using? So my request to you, doctors, if you could use your keypads or your any tool that you're using to answer this question. We have another 10 seconds to go. We are getting quite a few answers coming in. Now, is it less than 20% or higher as per the slabs which are given there? We'll close in 5 seconds. Biju, we can close the poll. Thank you, doctors, for your participation. The data very clearly shows, and thanks for your frank representation, that most of us say so far we were less than 20%, more than 57% responses, and which is very, very obvious because digitalization had not yet made inroads pre-COVID. And then that first slide that I spoke about said healthcare lags other industries as far as digitalization is concerned. So let's go to the next slide, where I want to throw a thought. Now we are hearing so much about digitalization and nothing can happen without digitalization. It may be true in other industries. But as far as Indian culture and Indian medical practice is concerned, I don't think digitalization can steamroll and convert an entire physical interface to digital. And I would leave it to Dr. Prasad and Dr. Pavan and Dr. Sanjay to address this later. But what I feel is there are some specialties, orthopedics for sure, where you cannot convert everything to digital. You need to see the patient. You need to do your surgeries where the patient has to be there. It can't be done virtually. And there are many other interfaces where you need the patient. Maybe, the sharing of reports can be done virtually. Maybe some follow-up consultations can be done virtually, like Dr. Pavan just said. The patient couldn't come, so he sent a photograph or a video or a clip where, maybe temporarily you can avoid a physical interface. But digital initiatives definitely can complement and supplement our practice. They can be great enablers, support, and backup to the various other interface elements that are there. And they can ease the time pressure, ease the burden on the patient to come in from long distances, and maybe come in once every second or third consultation. So that is something which can be worked out, and that is something which by default is being done today because the lockdown didn't permit them to come to us. So with this, I would like to go to the next copyright slide that I have. I don't think you would have seen it anywhere because it's been coined by us, which says that COVID, like other disruptors, has pushed digitalization from an optional peripherality. Pre-COVID, the digitalization in our lives was optional. It was peripheral. It was distant. It was not essential. So from an optional peripherality, digitalization today has become an essential centrality. And I think this is very obvious in medicine also, in orthopedics also. And therefore, digitalization is a must for us to remain relevant, to remain competitive, to remain progressive. But with the rider, it is for you and individually you only to decide how much of the digitalization and how soon the digitalization needs to be brought into your practice. And that is only going to be possible for you when you assess your own individual scenario, the skill set in your teams, and in the practice of orthopedics. So I'm no one to actually promote anything here, but some form and some extent and some speed of digitalization is mandatory. With that, I now go on to the poll question 2. The earlier question said pre-COVID, pre-current scenario. The second question says, how soon and how much of digitalization you think you will get into towards the end of 2020 or 21 once the pandemic phase of SARS-CoV-2 is over. So request you to start your polling. Will it increase? Will it remain the same? We have another 10 seconds to go. Requesting all doctors if you could give in your polls, please. We'll close in 5 seconds. Biju, we can close it. Thank you so much, doctors. Thank you so much. As is very visible and obvious, most of you have increased your percentage of digital initiatives beyond the 20%. In fact, very happy to see some response which is above 50%. So a clear indication of the trend line where the digital initiatives and the digital intervention, even in orthopedic practice, is definitely going to go up. How much, how soon, time will only say. With this, I come to my last slide because I try to keep it as compact as possible. But it will not be fair on my part, especially since I come from a defense family. My father was a naval aviator, and I know the importance of the defense personnel on the country's boundaries and the kind of great service that they're doing. COVID is a great medical emergency, unprecedented in our lives. And on my personal behalf, on behalf of Albert David and all countrymen across the country, I would like to salute and thank each one of you, dear doctors, and the entire healthcare professional community for the selfless, high-risk service that you all are performing in these very difficult, challenging, but needy COVID times. Thank you so much. And with that, I hope this session, though very short, has been of some use to all of us. Over to you, Dr. Prasad. Thank you so much.
Thank you, Dr. Parmar.
Dr. Prasad, I would like to request you now invite our second.
Ashish, Dr. Prasad could say a couple of words and then we can go to the next one.
I think I just saying you have given lots of points to ponder. So basically, these are the need of the hour. I think every health professional has to go into it. I know it's not practical, but I can tell you, friends, when you need something, you try to innovate. That type of trying time we're having, where we are going to innovate, these new ideas, implement there. So we are reacting to a situation which was unheard of, unimaginable, but yes, we humans have got the tendency and the capacity to fight all the adversaries. So this is what we are doing, and digitalization will be a great tool and help to to fight this adversity. That's all I can say. So it's a points to ponder. You've given a lot of inputs, which will be very good for our own colleagues.
Thank you so much, Dr. Prasad. If you could now take over the session 2
Yeah.
and
So
also introduce the speaker, please.
Yeah. We can go ahead, and can I have the CV of Dr. Sanjay Dhawan?
Yeah.
The next slide.
Yeah. So we will be sharing the screen
Yeah.
in which we will have Dr. Sanjay Dhawan's presentation.
And also his CV. So
Yeah.
Dr. Sanjay Dhawan is a great friend. He's from Agra, the city of Taj Mahal, as we all know. He's a young person, but doing everything. If you look at his slide, it's a very busy slide. Academic work, and also he's a great deal involved into the association work, the academic work of the association. And he's going to be the president-elect of our UPOA. So he's having both his hands full. He's doing his practice, even this hard time. I know because yesterday he had a patient who had a fractured tibia with vascular injuries, and he was trying to find solutions. So he has been a quiz master of UPA, that's why I said academic. He has been AO faculty and instructor in various AO courses. He has been executive member of the Central Zone of IOA, and he has gone vice president and DC member of UPA twice, vice president of Central Zone of IOA, joint secretary of IOA, and president-elect UPA. And he has been also honored with the Economic Times Inspiring Doctors of India Award. In fact, I'm happy because once the Economic Times started, my name was the first one to be given that award. And I got it. I think that was 3 years back. So with these words, I'll invite Dr. Sanjay Dhawan. One thing again I will tell about him, he's an excellent singer also. So definitely he cannot show that skill here, but definitely he will show his other skill of how to operate the upper range of tibia. Okay, Dr. Dhawan, all yours.
Thank you, sir. Thank you for those nice words. Can I have the slides, please? So I'll be speaking on hyperextension varus bicondylar tibial plateau fractures. The name given is HEVB-TP fractures. Next, please. Now, this is a case of 22-year-old male, had a history of fall from ladder. He has no comorbidities and no other bony injury. There was a massive swelling and no vascular involvement, but had a lateral popliteal nerve involved. And he was presented to me in plaster for 6 days. On 6th day, with the advice to go for a conservative treatment on this. Next, please. Now, if you see the X-ray, of course, if you get a CT in these cases, they are very helpful and they can guide you many hidden things. But unfortunately, I don't have that. But on X-ray, there is a sagittal plane malalignment where you have a loss of the normal posterior slope of the tibial plateau. Next, and then you have a tension fracture at the posterior cortex, which is very not obvious in this, but in AP you can appreciate that. And then you have anterior compression. Next, please. Compression, the anterior cortex. And fourth is the varus deformity. So these are the 4 components of these fractures which you need to address when you are going to manage these cases. Next, please. Now, this is what the posterior cortex was there. Injury is there. This is I have added later on because when I got this patient, I never had an idea that something of this sort exists. Of course, these fractures to me should be treated conservatively, should not be treated conservatively. They have to be done operative only. Plates are an obvious choice, but then you need to think which plate and where to put it. So what are the main concerns while we are operating in this patient? One is the displacement of the posterior hinge, and how to correct the anterior compression. And because whenever you are going to correct this slope, you will have an anterior void. So how to address that anterior void also? Next, please. So to me, it looked a different fracture from usual fracture patterns which we are treating. And what makes it different that there is a reversal of the normal tibial slope, which we don't find in other fractures of upper and tibia. Next, please. So with this idea that what exactly it is there and what we have to do, particularly to get a good result, so I just searched in the literature putting reverse slope injury in tibial plateau. And to my surprise, there was not much literature about it, but luckily I got this one paper by Raza Firazabadi et al. Of 2016, next, which speaks about all these features. And from there, I coined this HEVBTP fractures. Next. Now, they found in their study that the result was that these fractures, they are very notorious fractures and they are usually associated with significant about other injuries like popliteal artery disruption requiring repair to the tune of 12% in comparison to the other fractures where you don't have this hyperextension injury. Similarly, the partial or complete peroneal nerve injury and compartment syndrome were having a much more incidence in these hyperextension injury patients. Next. Next, please. So they found in their study that these fractures, they have got 4 hallmark pattern in common. One is the sagittal plane malalignment with loss of normal posterior slope of the tibial plateau. Second is the tension failure of the posterior cortex. Third is the compression of the anterior cortex. And fourth is the varus deformity in the coronal plane. Next, please. Most of the common classifications which are being used by Sashgar, Moores, or AOTA classification, which fulfills all the criteria and almost all the fracture patterns are covered. Even these, none of these, they cover this STVBTP fracture in any of their criteria. Next, please. But there has been a mention of analogous injury which has been described in the sports medicine literature, where you have a hyperextension varus injury, anteromedial impact fracture, posterior lateral coronary injury, and a posterior cruciate ligament disruption. Now, this hyperextension injury comes out to be similar to these injuries, but instead of getting that posterior cruciate ligament disruption, here posterior bony tension injury is there, where you have a fracture at the back of the tibia, just at the level of the insertion of the posterior PCL. Next, please. So they suggested that these fractures can be classified using AOTA classification, like 41C3.3 reverse slope extension. Next, please. They also described the 2 ways to fix these fractures. One is to address posteriorly and anteriorly. You fix posteriorly, correct with the plate and with the anterolateral plate. So you have to put 2 incisions, one posterior and one anterior. Next, please. Second is workhorse, where you can have a single incision anteriorly, where you can have a hinge screw which is put from anterior side, and you can put a lateral plate and an anteromedial plate. There you need not to go for a posterior approach. Sometimes when needed, you can use an additional anteromedial plate, posterior medial incision, and you can put a posterior medial plate. Next, please. Now next, please. So they concluded that this HEVBTB pattern is a unique fracture. The surgeon must recognize the possible associated injuries that accompany this injury. We suggest fixation strategies that address this injury's individual component, which may help you to avoid failure. Next, please. Second very recent paper of February 2020. Next, please. From PGI Chandigarh. They also have experience of this, and they have presented their work, and they concluded that tibial plateau fractures are complex and may result in suboptimal results despite a timely and excellent reduction. An important cause of this may be the initially inability to detect and correct sagittal malalignment consequent to a reversal of the posterior tibial slope. So both these papers, they are telling you the importance of reversal of the posterior tibial slope, and if you don't consider that, the results are going to be compromised. Next, please. Now, coming to my own case, now which fits into the same criteria of these fractures of hyperextension injuries. Next. Now see, this is peroperative picture where you put from an anterior approach, you are putting a hinge screw. This hinge screw is actually targeting to the apex of the deformity, that is just at the insertion of the PCL. You put that screw from anterior to posterior, that this screw helps you when you are trying to disengage the impaction on the anterior side and correct the slope. These fracture fragments, they tend to go back. So once you put this screw as a hinge screw there, once you are correcting this, next please, this will not go posterior, and you can correct without displacement. You are able to correct the slope. Next please. Second step is that you need to correct the articular alignment in AP and lateral view, all the fragments which are separate, and connect them with multiple K wires from lateral to medial and also from anterior to posterior. Now, once you have corrected this, then you can hold these K wires together, and then you can correct in the slope. You can lift it up, or you can take a blunt osteotome, or you can take a use of a laminar spreader from both the sides, and then you can correct the slope. Once you have corrected the slope, you need to hold hold with something. So you can use some block there. You can use some fibrillar graft or some bone substitute blocks that will maintain the corrected slope position there. Next, please. Now see. Now there is the fibula. You can appreciate the fibula just on the lateral side of the screw. Next, please. Oh, yeah. Put my older slides here. Okay, on one. No. Just go back. Go back. So once you have corrected this, then you can put a plate on the lateral side and a medial side. In my now there is another tip. Once you have corrected it, you can put a lateral. Once you are putting your lateral plate and you feel that your slope is still not corrected completely, then you can put the plate as a proximal screw parallel to the joint line, keeping your plate posteriorly to the shaft of the tibia. And once you have completed the fixation of all the screws on the proximal side, and now you lift your plate from posterior to anteriorly and make it aligned to the tibia, the remaining of the slope will be corrected. Next, please. So this is the final picture after correction, where you have a lateral plate, you have a medial plate, and the posterior medial plate. Next, please. Yes, this is the follow-up. Next, please. And this is the good functional outcome. No procurvatum deformity is there, and full range of movement and complete union with that. So this is, next please. To conclude, this hyperextension varus bicondylar tibial plateau fracture represents a unique pattern within tibial plateau fractures. The radiographic hallmark of this pattern are loss of normal posterior slope of the tibial articular surface, tension failure of the posterior cortex, compression of the anterior cortex, and varus deformity on the coronal plate. Surgeons should recognize this injury that can occur after a low energy mechanism in the elderly, especially because they are having a very osteoporotic bone, and always can be associated with the relatively high rate of neurovascular injuries. So you have to be aware when you have this hyperextension sort of injury, where you have a reversal slope, you tend to have the neurovascular injuries and high chances of getting compartment. And the described reduction and fixation strategies can be used to treat these injury patterns. Thank you. Over to the doctor.
Thank you, Dr. Dhawan. That was an excellent discussion, and that speaks volume because you tend to see the fractures first, and you think that accurate rejection will be good, but what the compression damage every time you miss, and looking at the alignment of the joint is very important. The fracture will heal, but the joint alignment will go, the slope will be gone, and what it will result in a definitely compromised outcome of the function, and the whole thing is lost. So that's very important point you brought in a very systematic way. I'm very happy looking at this, and especially a joint replacement surgeon. So I have to look at all the parameters of the joint level and how the slope is there. So now I will go for my case. If we can have my slides now.
Yes, sir. We invite you now, our most respected and regarded doctor, Dr. S. Prasad. I request you to present your case. Here is your case studies, the presentation ready, the screen.
Friends, I'll be talking here about the primary THR in the case of DDH. And I have been doing them since very beginning. Initially because of compulsions, now I really enjoy doing it. It's a challenge, and we all surgeons play with challenge. If there's no challenge, you don't like to work. The drive to do a good work is definitely a challenge very case. Next slide. It's a patient that I operated last year in August. So he was 38 years, now must be 39. 38 years old man that time. He had progressive limp right hip since childhood, but and had attacks of pain off and on. But since last couple of years, he started having very pain, which became severe and severe, and the limp became very pronounced. So almost since 2018, he started using a stick. He was showing it to many doctors. In fact, he came and shown me also, because I could find in record an old X-ray which was under my name. So, but definitely surgery is something, and people think, well, I was born with this and I've been living all around. Why now? So anyway, when he started having night cries, then he decided to opt for the surgery. On examination, all the movements of right hip are grossly restricted and painful. Limb length is shortening is there. The pelvis tilt is also there. So that enhances or accentuates the shortening. That means the hip is fixed in little abduction. External rotation was 10 degrees. Internal rotation was present, 5 degrees. And flexion was present up to 90 degrees. We were trying to fix the pelvis and see whether it was at the true hip joint or the pelvis was tilting. But anyway, we could get around 90 degrees of flexion. So he was able to sit very well when he used to come. Next slide. And this is the X-ray. Now basic X-ray also gives us a lot of information. I think now we are used to getting CTs done. But if you look at this, we can easily see which group it belongs to. It belongs to group 4 because the hip is absolutely dislocated. You can see and appreciate the true acetabulum by looking at the teardrop of both the acetabulum and see the hip is rotated. Which one? Where? For that we need a true X-ray or a transgluteal X-ray. However, we have got CTs now, so we go and get a CT done. But first try to see where the acetabulum is, because that's a very, very important point if we want to go ahead for the surgery. So surgery definitely should be done. We cannot leave him like that. And I'll be telling you all theories apart. I'll be telling you simply stepwise how I go about now in handling a dysplasia and trying to convert it with a primary THR. And most of the time, this is the normal workflow in a case of DDH. And I'll be on every step, I'll be telling you the options available also. Next slide. So you see, I just have marked where the acetabulum is and where the head is. I cannot find, but it should be somewhere high up. And we can appreciate the trochanter. We can appreciate how the pelvis is tilted and be compensating the shortening. Next slide. So this is the CT, and you can appreciate a lot of things on CT. I'm not showing all the CT images to the 3D reconstruction. Next slide. Next. So look at the points we must appreciate in CT. The one group will be in proximal femur. So what we have to appreciate the anteversion of the neck and the length, neck shaft angle, mostly it is in valgus, the medullary canal diameter, because that will tell us some idea about whatever implant we are going to use. How much shortening is there? Next slide. We also look at the cross sections. And next slide. And then we have to appreciate the size. What is the size? Bone has been formed. How much calcification or ossification is there? What is the shape of the ostium? How much shallow is there? How much depth is there? How are the pillars placed? And how much the pelvis is anteverted? How much anteversion of the acetabulum is there? So these two things, the proximal femur and the socket, we have to really appreciate and visualize what we are going to do, how to make the two match again as a natural hip joint. Next slide. So what is your choice of approach? If we can have a ARS, something like that, because it's a hip joint, hip replacement, all of us do it, not a big issue now. So what will be yours? If you can give answers, I would be very happy to appreciate that.
We have 15 seconds.
If there are people who can answer it, so that's welcome. That's interesting. Okay, fine. I can.
We'll end the poll, doctor.
Yeah, you can. So mostly it's posterolateral, but I'm very happy to see one direct anterior. Yes, nowadays it is being advocated that direct anterior can really work well because it will not compromise the soft tissue much more and the chances of dislocation is less. But friends, it is not easy job to do a DDH by anterior approach. But people who do it, they advocate it strongly because this strong anterior tissue which has fibrosis can be dissected very well by this direct anterior approach. However, next slide. Can I get the slide? Yeah. So what is the goal? We want a biomechanically stable hip, so a good total hip, and it has to be stable. Restoration of normal center of rotation as far as possible. So our aim should be perfection. We can compromise. Some outliers are there, which I'll discuss. Limb length discrepancies to be managed. That means we try to get back the limb length as far as possible. Again, outliers are there. We will discuss when the time comes. But most important, visualize with the CT and X-ray what are the implants we are going to need. Definitely, we are going to need a small cup which can fit into a small acetabulum. Remember, friends, if you want to do a cemented acetabulum, then you have to ream much more. And then if you don't have much bone, then you will not be able to ream. So cement, so for the same amount of reaming, the size of the acetabulum will be much smaller. So you have to leave 4 millimeter of cement mantle or 2 to 4 millimeter of cement mantle all around. My slides are not there, my friend. Can I get my slide with you? In dysplasia, definitely I cannot. But anyway, I can discuss a couple of things. So you have to arrange and visualize what are the implants you want. So in acetabulum side, you must have a small cup which can be fixed. In dysplasia, don't try to think that you will not use a screw. I don't like to use fixation screw in acetabulum, but definitely in dysplasia, in rheumatoid, I do use them. In dysplasia, where the chronic bone change, and you cannot appreciate the type of bone we have. So we must have very small cups with us. If we have to do a subtrochanteric osteotomy, we must have a discal fixation stems also. Appreciate the medullary canal diameter. So what stems you like, arrange them. You must be prepared for bone grafting as well. Can we go back? We have gone very ahead, very ahead. Still back, still back, still back. Yeah, we are here. So just no, go ahead. Yeah, stay here. So small cups, I told you, distal fixation stem if subtrochanteric osteotomy or derotation osteotomy is needed. Bone graft fixation. So we must have all plates, small plates which we use in acetabulum and proximal femur. We might have to use all the screws, matching screws we must have. So keep all my armamentarium together. Next slide. And now this is my exposure. I have been trained in both the posterolateral posterior approach rather what I was taught in my college. Later on, I started doing hardening with posterior dislocation. In Germany, I was always doing hardening with anterior dislocation also. So both the approaches I became very good familiar. But in revision cases, it's always good to go posterior dislocation. And now I have stuck to because my associates always wanted to do posterior dislocation where they can see it better. So the exposure is same. I will always, normally I'm a very mean surgeon. That means I will not take out a lot of soft tissue. I do not take out, apart from the rotated gamellae, I try to even preserve piriformis if possible. It creates a lot of more tension, then definitely I'll transact it and stitch it back. Quadratus, I try to just squeeze a little, never go to the vessels, never. Sometimes accidental, you can go there. Next slide. But here I have got a couple of things. Number one, and this is very, very important. That's why I said the first is skin incision, the second is release around proximal femur and resection of the neck. Neck should be resected closest to the lesser trochanter, so that the neck shaft angle of the prosthesis or the implant becomes your neck shaft angle. You are not guided by the neck shaft angle of the anatomy. So neck should be resected closest to the left trochanter, hardly 0.5 centimeter I leave there, bone in the calcar part. Rotators and piriformis are set. Piriformis is stitched back, which on if possible. Gluteus maximum tendon is cut and to be stitched back later. IT band, if it's contracted and is not allowing the proximal femur to move, you can transact it. So idea is to make the proximal femur very mobile and then go around proximal femur and keeping close to the bone, the anterior part of the femur. Remember, you have to take out and slide. The abductors have to be arranged. That is a good band. So we must remember that abductor power, if damaged, will lead to a limp in the gait later on. So try to protect the soft tissue, but also try to mobilize the proximal femur. Keep on rotating, external rotation, internal rotation, and keep on rotating. You must be able to hold the proximal femur and take it anterior and posterior, mediolateral, all type of movement. When you are free, because acetabulum is not visible, it will be visible as a flat, soft tissue bed, because you cannot appreciate the depth of the socket. The false acetabulum will be visible once you have taken out the head. So that this part is very, very important, and I'll tell you why it is important. Number one, and then identify the sciatic nerve and keep away from the section area, because when you cannot see, you may go little posterior, whole posterior, trying to find out the true acetabulum. So don't do that mistake. You know the where sciatic nerve is. You may not have to dissect it all the time. Just identify it and keep it away from your dissection. Right? So this slide is very, very important and try to do it. So instead of finding acetabulum, first do this. Try to mobilize the proximal femur. Next slide. Then find out the acetabulum. And I always take the help of image engine file. When we have got a tool, why not? I can be sure, no, I think it is there, but still I'll not go ahead. After I have started doing joint replacement in 1990, so it's almost 30 years of experience, but no experience, nothing. I will always try to confirm it again before I go ahead and remove all the soft tissue. It has to be very, very slow. It's like you see in China salami slicing technique. So go gradually and find out. Start from the inferior border of the cerebellum, then try to find out both pillars. I use the athermy, but I really take care because the sciatic nerve, we cannot go more posteriorly. So it takes time, but try to find out the true acetabulum. There have been a couple of papers which have shown very good results when you have done acetabulum fixation, a hybrid. Means you have not gone exactly at the false acetabulum and you have taken the superior rim of the acetabulum, true acetabulum, and implanted the socket there. But nowadays, the concept is try to find the true acetabulum and fix the acetabulum there. That will give the best longevity, and we have to not only give a short-term result. You see, they will come back. I have just revised hip replacement, which I had done in '93. A patient whose hip replacement I had done in '95 is waiting for a revision after my life. Why you have stopped doing surgery at the moment? Anyway, so you have to do it very well. So try to find the true acetabulum, locate your cup there, and there only. Next slide. Next slide. Then ream progressively. Once you have identified these, and just don't shy away. So then before reaming also, look at the direction in the image interface. Yes, you are reaming in the right direction or not. And try to keep both the pillars fixed because your cup is going to sit between the anterior and posterior pillar. So and try to keep your socket down. So just take out the cal. If now mostly it becomes visible even such cases. So see that you're going parallel to the cal. That will give us some good antiversion and you will give them good pillars from both sides to fix it and hold the cup. Next slide. If you have to increase the depth, we have got two methods which work very well. Number one, take a piece of the head. We can apply it over the superior or posterior superior portion. Help it, fix it with the screws, and then ream and apply the cup. That's one. We can use a small acetabulum fixation page also on the superior surface and hold the graft there. So that is one technique to increase the depth of the acetabulum so that the cup can be taken up if there's a shallow acetabulum. Next slide. Another one which I have been using quite often is to increase the depth to on reaming till we can see the membrane of the medial wall of the acetabulum. Or just before that, you can always check with a drill making a hole and the depth is a minimum bore. Just take a small osteotome and just cut very gently. Don't try to break the membrane at the medial wall. Pack all the reaming bone or take out cancellous bone from the head and make a paste, impact it there, and then apply the trowel and see if it's good. Apply the socket. So both the things, you can increase the depth of the acetabulum and will give you enough bone all around to fix and stabilize the acetabulum. So this is the very important step. Once you have done acetabulum at the original acetabular level, at the original socket, 50% of the job is done. And this will lead to a good long-term outcome for the patient and very good functional outcome. Next slide. So this is just to show another case of dysphagia, and again I have taken perforating the medial wall and going inside, and it's after many years and still doing so. I think it's a 2012 X-ray. So that time it was a follow-up. So it must be more than 10 years now. Next slide. Then, even once you have fixed the trial, don't shy away. Again, check with the image in the trial. That you are happy with the trial, the position, the toe, and you see the femur is displayed well. So the proximal femur should have been mobilized well. And then we fix the cup. So that way, 50% of the job is done. And then now the things are very easy because femur you can handle well. Next slide. So now stem, trial length, and antiversion. These are the so pull and assess the level of neck in relation to the scapular implant. So now you have got a loose proximal femur in 20 degree of flexion where knee is flexed because your sciatic nerve should not be pulled. Pull it, keep a finger over the sciatic nerve, look at the tension and try to push your trochanter till the level of scapular margin and see whether it's going there. If it's going there, that means you will be able to relocate without doing a shortening of the proximal femur. And that's a good news, but with a catch. You'll have to simply watch the sciatic nerve. But I can tell you, if you have done well, no, most of the sciatic nerve, we look at the literature, they are not damaged by traction alone, because then you can keep your knee and hip flexed post-operatively for 3 weeks and gradually mobilize them. Most of the time, the sciatic nerve is damaged directly, then only it goes away. This is a recent paper. So now do a rasping, use a 2-size smaller stem in a planned antiversion which you have planned, and use a trial and try to reduce it. And then see how the antiversion, because antiversion of acetabulum was the best antiversion possible to get a very good cuff fixation. So now you have to match the antiversion of the stem to the antiversion of acetabulum which we have already fixed. So let it be a matching or make it coplanar. So you can, when you have got a loose stem, which you can plan how much antiversion you look at all the parameters and then apply a stem. Check stability, combined antiversion, rasp and fix the required stem in desired and planned antiversion. Keep on checking the sciatic nerve, accept a little shortening if necessary. If not happy or tension is high, prepare for subtrochanter or the shortening femoral osteotomy. Next slide. So this is how we do. We do a shortening subtrochanteric osteotomy, and we have to fix a stem now which engages a distal cortex or distal femur also. So that's very important. Next slide. How we do it. This is what I did in this case. So we could manage very well. You see the neck resection is very close to the subtrochanteric. In fact, we cannot appreciate the calcar here, but I'll show you the X-ray when the final X-ray is there. This we confirmed under the imaging. Next slide. And this is the X-ray you can see. So minimum of calcar you'll see, but that gives a very good neck shaft angle, and the lesser trochanter is almost brought to the same level. Most of the deformities of the pelvis tilt will go gradually. Next slide. Okay, so again, Viju sir, you have not used my new slide because there is a technique how to do a subtrochanteric rotational osteotomy. But anyway, I'll not go into detail because that surgery was not required in this case.
Sir, we have the video. Can you show the video? We will be showing you.
Can you show the video?
Yes.
We got the video like Dr. Pawan, because the patient has not come to me now because of COVID. So almost length is gone. He is very happy. We have to train him for his abductors and gluteal muscle exercises to get a perfect shape. He is very happy, no foot drop, nothing. We kept him on for 3 weeks with the knee and hip flexed and kept on looking gradually expanding, but he never had any paresthesia or anything, so we allowed him to walk next day only. So this is what we do in a DGHA, and DDH case. And most of the time, friends, we go stepwise, we will be able to do a good case. The only thing, the catch which I have done, or rather I do a subtrochanteric osteotomy when I am afraid of mobility. Otherwise, most of the time I am able to mobilize the femur well with a suitable dissection, keeping close to the femur, going all around and keeping the don't. But we cannot cut simply the abductor muscles, but we can tease a little fiber there. We can just go at the trochanter and see the adhesions we must take out. Don't try to cut muscle directly, but all the adhesions can be taken out. All the fibrous tissue which forms all around can be definitely taken out. So, and that will lead to lot of mobilization, and ultimately that will lead to a very great outcome for the patient as well as yours. Both will be happy. Thank you. Thank the Lord. We can take questions if there are any.
Thank you so much for an excellent, detailed overview of 30 years of your experience, Dr. Prasad. There are a couple of questions which have come in. I'll just read them out, and then you could moderate the questions within the panel. One is, what did you do for CPN involvement? Tub osteomyelitis, question mark. Popliteal nerve, not CPN. So I'll just club the questions. There were quite a few of them. So these are the 3 points which have come in. Over to you, sir. Dr. Prasad, you could moderate these now.
I think both. Dr. Pawan to start with. Did you hear the question, sir? Could you?
Yeah, can you just repeat the questions again, Dr. Tony?
Yeah, sure. I'll just do that. What you did for CPN involvement?
Common peroneal nerve involvement.
That's
that
right.
Is for probably for Dr. Sanjay.
Okay. And tub osteomyelitis?
Tub osteomyelitis.
Yeah.
TUB.
TUB.
Okay.
And popliteal nerve, not CPN.
Sorry, what's that?
Popliteal nerve, not CPN.
Popliteal nerve involvement.
I think Dr. Sanjay sir did mention about the common peroneal nerve being involved in the hyperextension virus injury.
Might be.
Is that correct?
Might. Yes, he said might be.
Probably the question is.
No, it was involved in that patient and it recovered in due course of time in 3 months.
Achha, you didn't do anything primarily for that?
Primary did nothing because I was waiting for that. Because literature also says that most of the time they do recover. But if you have an arterial injury, of course you need to go for an arterial angiogram and work accordingly.
All right.
Dr. Pawan, I can ask you a question. Why did you use a hinge knee brace for the patellar osteomyelitis?
Yes, doctor. So I first used a knee brace, the long knee brace, for about 3 weeks. And as usual, I like the hinged knee brace personally. But then usually what happens is when there is, so I want a direction to happen in one plane. So usually after an arthroscope, and I just did a little bit of trimming of the meniscus as well for that patient. So I just wanted unidirectional motion. Initially, only for about a week, I used hinged knee brace. Then I got rid of it.
Okay. So, because any it's okay then. I wanted to know the logic behind why hinged knee brace.
I prefer hinged knee brace because usually after arthroscopy, I usually give a round knee brace if it's a ligament reconstruction. If not, I just give a hinged knee brace so that the movement is intact.
Prasad sir, can I ask one question?
Yeah, sure.
Sir, how do you decide to go for osteotomy on table? What are the basic points that you find on table to decide?
Well, first, that was the one side like yours. They omitted the another presentation. So basically, what we do, if it is not reducible, if you try to pull it up, and your lesser trochanter comes at the level of superior pole of escabulum, that means we need a osteotomy. Then, because we already have done all the proximal femoral releases, so no more releases can be done. So we try to pull at 20 degree of flexion, knee 90 degree flexion, and just then pull this away. And you can just give a thumb pressure and see how much the trochanteric tip goes to the level of scapula. What is the relation? If the whole neck part is at the superior part of the scapulum, then I think it's prudent to go for a subtrochanteric osteotomy. That's number one. Number two, for doing an osteotomy, we have to do a trialing first, look at how the stem behaves. Then we do an subtrochanteric osteotomy. The first osteotomy is usually I do a transverse one with a peak. I can always label and make a socket so that it's lost later on. So I'll do a subtrochanteric osteotomy at around 1.5 to 2 centimeters distal to the lesser trochanter. Then I will reduce the proximal femur with this trials on into the scapula, and again pull the distal femur and see how much overlapping the femur has from the distal cut surface of the proximal femur and the proximal distal femur का जो cut surface होता है उससे. The amount of overlapping we have, that much of bone from the distal femur has to be taken off. So I will just take little less. So I'll make a notch here, keeping the anterior. We always make a mark that is standard with the diatony, so we know what was the normal femoral rotation. Now we can plan and make a notch so that it works well. Hold it there with a clasp and then do a proper stem. So I use Astrom and I have also used Wagner. These two stems, I have used solution stem also, but I still think Astrom and Wagner are good stem to hold this type of subtrochanteric osteotomy. So this is how you decide, and now you remember your hip is relocated. So your femur, so these two should match. So your length is gained. Any other thing?
Yeah, you already answered. You already answered my second question, which I was going to ask you. That how to decide how much to cut.
Okay, so but this osteotomy has to be like this only. Why you are doing an osteotomy not to create a different angle. You are doing an osteotomy to do a shortening, and this category is only to lock both the femur. But if you don't lock, you don't make a notch there, or still there have been 4 types of subtrochanteric osteotomy: the elliptical one, the locking one, the sagittal one. So there are many people who have already tried to find out how to lock both the femur together. If not, you simply push up a distal fixation stem, and the vertical loading will lead to bony healing. So no issues there. You can make it absolute transverse osteotomy as well.
Dr. Sanjay, I had a question for you. Yeah, am I audible? Yeah, so first of all, wonderful case which you had there, that's hyperextension and the varus. So in my personal experience, I've seen these on field with a lot of rugby players who have these hyperextension injuries where they have a kick from inside and they try to stop. And you also very well pointed out that it is common, the common injury is PCL avulsion with PLC, posterior lateral collar injury with an anterior, compression of the anterior tibial joint line. So in your case, of course, the way you try to hold the posterior cortex with a long screw, that's a very important tip and something to learn from you. Now, post-operatively, did he have any PLC injury or PLC laxity or varus of the knee, varus thrust while walking or something like that?
No, he didn't have anything. First, get a fracture of the bone posteriorly, or complication of posterior lateral collar is less. It only happens when you don't have a bony injury right there, because the most of the load is taken by bone. If bone is fractured, if it doesn't get fractured, then the soft tissue is much higher. Because in these sports injury sort of thing is there. So once it gets fractured, half or 2/3 is taken by bone. The force is less on the though you have a posterior lateral column injury. That's why you have that vascular and neurovascular problems. But so that I didn't have, he didn't have any laxity. So I have a series of cases like that. None of them, fortunately, have this problem.
Yeah, I mean, of course, you did mention that it was a low velocity trauma, and also you told that those cause these fractures typically.
I think that we can call it a day. It's already time, Dr. Parmar.
Yeah, sir. Now my national sales manager, Mr. Srivastav, Yogesh Srivastav is there. I request him to please give a vote of thanks for this wonderful session, so enlightening, so resourceful. I think all the audience must have enjoyed thoroughly. Yogesh, over to you.
Sir, I would like to express my thanks to, on behalf of the chairperson, Dr. K. Sir, moderator, Dr. and the speakers, Dr. and Dr. Sanjay, for their guidance on this topic. I would also like to extend my thanks to all who have been here, taken their valuable time to attend this webinar. And we at Albert David will continue our pursuit to provide such platform in near future for continuous knowledge enhancement, and definitely through this Vedana platform, which we have formed on recently, particularly in this COVID period. Thank you so much, sir. Thank you.
Thank you. It was a pleasure.
Thank you, everyone. Thank you so much.
Okay, sir. Bye-bye, everybody.
Thank you.
Bye, Dr. Pawan. Bye, Sanjay. So, Dada, agli baar try you to send your song also.
Only behind you.
Okay, bye.
Bye. Thank you, Bhavan, and thank you, everyone.
Okay.
Thank you, Dr. Sanjay.
Okay.
Bye.